I am Dr. Joseph Bavaria. I'm the chairman of the Department of Cardiovascular Surgery at Jefferson Health in Philadelphia, as well as the president of the Heart and Vascular Institute. Basically, what the concept is that you take a zone 2 arch graft, which is an open graft, and the anastomosis distally is just right before the subclavian artery, and and then you have a pre-made, so to speak, created landing zone of Dacron between in zone 2 between the subclavian and the carotid arteries, and then you do a standard operation where you do an anastomosis to the left common carotid and a nominant artery. So this is known as the zone 2 arch. So once we finish the open procedure, we then wait and we'll do it sometimes between 30 and 90 days, come back and do a GORE TBE that lands into zone 2. But now this zone 2 is Dacron and completely created for this landing zone. It's very, very straightforward. And then we usually will take the TBE graft down to the mid-thoracic aorta and then usually extend it in the sequential phase to about 5 centimeters above the celiac. We generally will put in a 28 or a 30 or even a 32 millimeter aorta, Dacron aorta, which would allow a big TBE, even up to a 34 or 37 millimeter TBE graft. So that's important because when we have a big graft like that, we can use the 12 millimeter portal, which has excellent inflow into the subclavian artery. It's a simpler operation than a zone 3 arch, so or a FET. We don't have to go into zone 3. And if you look at a standard FET series, there's a significant number of tracheostomies and basically pulmonary issues that are related to the problems with the nerves that are right there. So this stays anterior to the nerves that are so important. And it's easier because it's not as deep into the chest as a zone 3 arch or a FET. The other issue is that it avoids the left subclavian artery. The left subclavian artery is quite difficult. It adds a lot of time to an arch procedure. It's sometimes it has to be done extra anatomic, which means that you have to go into another cavity. It's just it basically takes the pain away from dealing with the subclavian artery and leaves it for the TBE graft, which was specifically designed in this to deal with the subclavian artery. So it's like the perfect marriage. So the paraplegia risk in our series is 0. Acute type A dissection is a total aortic catastrophe. What happens is we have basically 3 types of presentations of acute type A dissection. The first type is an more elderly patient who comes in with an acute type A dissection. Really what we're trying to do there is make sure they don't die. The second type is a person who has an acute type A dissection who has either a very, very kind of a severe distal malperfusion, which needs to be taken care of right away, or the therapy needs to be directed acutely, or a kind of what we have is an arch where the arch is blown up. In other words, this is a non-A, non-B type of dissection where the primary tear site's in the arch and the arch is really in a bad way. So those 2 indications, which represents probably 20%, maybe 25% of all acute type aortic dissections, those are actually the type of patients who need a FET. But that means we also have about 60% of the patients who are, stable is the wrong word for a type A dissection, but are relatively stable. They're younger, they're relatively stable, they're less than, say, 65 or 70 years of age, and they have a type A aortic dissection. And in those patients, which is the majority of patients, we would do a zone 2 arch as the index procedure, and then within 90 days, let them get over their procedure, and within 90 days, perform a GORE TBE graft. It's important to recognize that we need to do it less than 90 days after the type A dissection happens. And the reason for that is that we want to be able to move the membrane and have apposition between the membrane and the opposite aortic wall. So what we find is that when we do the zone 2 arch and acute type A dissection, 40% of those patients don't need anything. So we actually end up only putting in the zone 2 TBE in 60% of those of that group. So that's very, very interesting. The second indication is the chronic dissection. Now, a chronic dissection in this case, is a residual dissection after a DeBakey type 1. So, for example, patients may be 1, 2, 3, or 4 years after their initial operation, which is usually just a straightforward ascending graft, and now they've got a degenerated aneurysmal arch and descending aorta, and maybe even a thoracoabdominal aorta. So, in those cases, what we do is we'll go and do a redo operation from the front, do a zone 2 arch, create the landing zone, and create the entire technical operation to accept a TEVAR solution. And in this case, it's a TBE graft because it's a zone 2 arch. And that's actually, believe it or not, the number one of all the cases I've done and our group has done. This is the most common indication, actually. So the third indication is an aneurysm case. Now, these are usually atherosclerotic aneurysms. So in these kind of cases, we're quite worried about the incidence of paraplegia with a FET. Sometimes you will get, if you look at the FET series, the paraplegia rates are between 4 and 7%. So in those cases that we think there's a problem, we will stage it with a zone 2 arch. So this gives you a complete and total thoracic solution to the acute dissection, to the chronic dissection, and to even an aneurysm as well.